Morning. We are going to have a very useful and interesting session today, and it is presented by a very efficient, well-known cosmetic dermatologist. He is basically a dermatologist and got interested in cosmetology, and now presently handling the cosmetology in Amala Institute of Medical Sciences. And she has trained a lot of postgraduates and others in the field of cosmetology. And she has vast experience in various cosmetic procedures, especially the PR. So Dr. Roshan is part of Department of Dermatology in Amala Institute of Medical Sciences, and she is very actively into cosmetic dermatology. Now, over to Dr. Roshan.
Okay, thank you, sir, for that description. Whatever I've learned is from all of my professors, especially you, sir. So first of all, thank you for this opportunity, sir, and also to East West Pharma, especially Naveen, for giving this platform. So I think a lot of postgraduates are joining us today. So I'll just share my screen. At the end of this session, you'll at least get some pointers or at least have a good guideline of how you can do a proper PRP in various indications. So we'll start with platelet-rich plasma in dermatology. So I hope to cover this topic by going through these following headings. What is PRP, the mechanism, indication, and I want to give more importance to some controversies or some confusions that keep arising. So that's what I would, because how to do PRP, I don't think a lot of training is needed now. Everyone is currently doing it pan-India, and so many quacks and even beauty parlors have started venturing into this procedure. So as doctors, with the evidence that is available with us, how we can approach this is what I want to make clear in this presentation. So first of all, we all know what is PRP. So the proper definition, it is an autologous plasma product which contains high concentration of platelets. Now we know the normal count is around 1 to 4 lakh platelets per microliter of blood. So PRP after the preparation should have 2 to 5 times higher than the normal baseline. So you can say it's almost 10 lakh platelets per microliter. This is how a proper PRP concentration should have platelet count. It should be 2 to 5 times higher than the baseline. So we know it's a very versatile substance. It's used in so many areas of medicine because it promotes healing, angiogenesis. That's why it's also called a healing juice in circles. And as it's an autologous product, there's very minimal risk of allergy or rejection from the body. So a bit about the history. So you can see as early as in the 1950s, Kingsley already coined the term PRP. So this substance has already come into the market as early as the 1950s. And in 1970s, a fibrin glue was introduced that was used in wound healing. And in the 1980s, Knighton showed that this could be used to promote healing in ulcers. Then it was in 19, so by then the PRP is already well being used, especially in orthopedics and surgeons for their wound healing and ulcers. Then in 98 is when the proper definition of PRP came across. Like I said earlier, 5 ml of plasma should contain 1 million platelets per microliter. Then it was in the 2000s that PRF was developed, platelet-rich fibrin. And in that, there was advanced PRF and injectable PRF also. So this was the chronological history of how PRP was developed. Now, these are all eminent sports personalities. So this is how PRP started becoming famous. You can see Tiger Woods and Rafael Nadal. They started injecting PRP into their wounds and for knee joints and all. And then it was Kim Kardashian who brought out this procedure called a PRP injected on the skin. So that term called vampire facial came into vogue. So a steady transition into dermatology, aesthetics, and especially trichology started to come up. So if you do a literature search, there's such a wealth of data. There's so many articles, but there's there is no standardized protocol. There is a lack of consensus. Some people say you have to spin it like this. Some people say you need this much blood, activation, coagulation. So it's a lot of confusion. So there's no proper guidelines. So that is when our IADVL brought about a proper set of common guidelines. They actually created a PRP task force, and they did an extensive and exhaustive literature search. And from that strong recommendation, weak, moderate recommendation, they brought about these guidelines. So at least someone who's starting PRP for the first time can at least follow this. So that's what I would like to highlight in the coming slides. Right. So these are some terminology I think everyone should always be familiar with, because what is happening nowadays, the patients are so well read. They are going to come and ask you specifically that they want PRFM or they want EXOSOME or QR68. So at that time, we shouldn't be fumbling. We should know exactly what they are talking about. And we should understand that their knowledge is always half-baked. So we should have the proper armamentarium to counsel them what kind of preparation they need for their condition. Okay. So PRP is platelet-rich plasma. Then there's platelet poor. There is leukocyte-rich. PRFM is the matrix platelet gel I told earlier. Then biofillers, that's a new thing. It is an inert coagulum of plasma proteins. All these are already pre-made in the lab. ACDA, I'll be coming in the following slides. It's the anticoagulant that is added to the tubes. Revolutions per minute and the relative centrifugal force are measurements of the centrifuge machine that we use, growth factors, injectable and advanced PR. So at least you should know these terms when you start doing this procedure. Right. So this is like a basic classification of PRP. These are the 4 products that you can get. So the leukocyte pure or the pure platelet-rich plasma. So this is the component that we use for androgenic alopecia and even for facial rejuvenation. So in this, there is absent or very low leukocytes and a low density fibrin network. Then there is the leukocyte-rich PRP. So these are products with leukocytes. So the difference between these two, the leukocyte poor is what we use in dermatology for the scalp and the face injection. Leukocyte-rich PRP is used by orthopedicians. It's for harder connective tissue. That's the basic difference. Then these two are PRF, platelet-rich fibrin, and the leukocyte-rich, platelet-rich fibrin. That is used for ulcers, wound healing, etc. So this is the basic general classification. So these are the dermatological indications. Mostly for androgenic alopecia areata, even for telogen effluvium, now it's being given. Then a lot of acne scar rejuvenation. We can use it in combination with fractional CO2, microneedling, and even our subcision. It's used for stretch mark treatments, for skin rejuvenation. Even for this under eye dark pigmentation, we use a lot of PRP nowadays, periorbital melanosis. Then indications with very low strength of recommendation are vitiligo and melasma. There are not many studies to support it, but people are giving it. And these are the non-derm indications. It's being used in, you can see, so many areas in medicine. Gynecology, especially with cosmetic gynecology, is a big boom nowadays. Many people are undergoing fellowships for gynec training. So they use it for ovarian and vaginal rejuvenation, even for I think after prolapse of uterus for strengthening of the ligaments or the ovarian uterine ligaments, they're using it in gynecology. So those are the non-derm indications. Right. So there are contraindications for PRP. Obviously, if the patient is hemodynamically unstable or if there are hematological malignancies, if the platelet count is very low, we cannot give PRP. In pregnancy, it's actually not a contraindication. Can be given in pregnancy and even in lactation, but obviously we don't do it. Then these are the relative contraindications. Always, if your patient is coming to you the first time, it's always good to get a complete blood count. See if the hemoglobin and the platelet count are in the normal range, and then only start the treatment. Yeah. So those are the contraindications. Now we'll go into the mechanism of action. So we know PRP is injected and growth factors are released. So these will stimulate angiogenesis, cause fibroblast proliferation. It enhances wound healing. So how exactly it acts for PRP is what we have to learn. So these are all the major growth factors that are released. In this, what I have to highlight is VEGF, vascular endothelial growth factor. So that is what you call the master regulator in angiogenesis, because it stimulates endothelial proliferation and migration and new capillary sprouting. So VEGF can be called as the master regulator in this PRP activation. Right. This is again all the growth factors which are released in after PRP injection. So what happens is the growth factors, they act on the stem cells in the bulge area of the hair follicle. So this stimulates development of new follicles. That is where the action, especially in the bulge area, there are the dermal papilla cells. That is where the specific action goes. So a lot of the signal-regulated kinases are expressed, and it produces an anti-apoptotic effect. So what happens is this prolongs the anagen phase of the hair cycle. That is what we are aiming to do, because you have to counsel the patient very carefully when they come with androgenetic alopecia. This is not going to get reversed. Already the follicular miniaturization, everything has already begun. It's very hard to reverse this process. So what we are trying to do is at least prolong the anagen phase of the hair cycle and delay progression into catagen. That's what we are trying to offer to them. So always make their expectations very realistic. Right. So this is the rationale for PRP use. The dermal papilla is the source of production of various growth factors. They are responsible for maintaining the anagen phase. So we target those will upregulate the growth factors and lengthen the anagen phase. I think this is the main point, that you should understand the mechanism of action of PRP. Right. So these are two topics that's always causing a confusion, and many people give different consensus. So let's see what the literature has to say. Activation of PRP. So basically, what does that mean? We collect the PRP and we inject it. How is it getting activated? So this refers to two processes. One is release of growth factors from the platelets. Other is cleavage of the fibrinogen to form the matrix. That is what is the meaning of activation of PRP. So we can either do it exogenously or it's already being done endogenously. So exogenously, many people, especially the companies, will tell outside we have to inject it with some calcium chloride, then only more platelets will be released. That is an exogenous type of activation. But what we follow, there is actually no need to activate PRP, because once it is injected into soft tissues, the type 1 collagen that is already in our blood is going to activate the PRP. So broadly, if you look at the literature, that's what they're saying. For soft tissue injection, an external activation of PRP is actually not needed. But if you're using for people in orthopedics, they might need, because they are injecting into hard connective tissue. So an activation will help in maintaining the integrity of the PRP, is what is being said. So as a rule, PRP for our indications, an external activation is usually not needed. Right. So this is how it acts. Once we inject the PRP, the platelets will begin to secrete growth factors and cytokines within 10 minutes itself. And within 1 hour, already 95% of the growth factors are synthesized. And after that initial burst, over 5 to 10 days, low amounts of platelets continue to keep secreting. So this is how it goes after PRP is injected. So these are the common platelet activators. If it is being done exogenously, there is thrombin, calcium chloride plus thrombin. Then there is type 1 collagen. Type 1 collagen is already present in the blood, but it can also, some people also inject it exogenously. So broadly, these are the platelet activators that are commonly used. So I hope you've understood about activation. Now we'll come to the anticoagulant. So the PRP tubes that we use always contain an anticoagulant. It should. So why do we need an anticoagulant? It prevents clot formation. Immediately when the blood is drawn, the platelets will usually get activated and the clotting cascade is triggered. If the clot is formed, then we can't separate the platelets. So an anticoagulant will prevent that clot formation. It will keep the platelets intact. The platelet membrane won't be damaged, and it will allow proper separation in the centrifuge. So these are the actions of an anticoagulant. So how do we choose one? So these two are the recommended ones. You commonly heard of ACDA and sodium citrate. These are good choices for PRP, and most commonly our tubes will contain either of these two. These are ideal for PRP because it helps the activation and it maintains the integrity also. Then these should be used cautiously or maybe not even used. Heparin especially should actually not be used. EDTA is not recommended anymore because it damages the platelet membrane. So always ACDA and sodium citrate are more recommended. That was about anticoagulant. So activation of PRP and anticoagulant, I hope it's a little clear. So what you have to consider when you choose an anticoagulant is the platelet function. Select one that will prevent platelet lysis. Then select those that are good at retaining important growth factors, and depends on your clinical application also. Like for hard connective tissue ones, maybe the other ones might be okay, right? Okay. So now we'll come into the PRP, the method proper. So all of us know we draw the blood. So here are a few things that I want to highlight. We always use large bone needles and use the larger cubital veins. There are 2 spins. We collect these into tubes containing anticoagulant. There is the soft spin and there is the hard spin. So let's go into these in detail. Right. So we collect whole blood. In the first spin, there is separation of platelets. We transfer that into a sterile tube. Second spin. Yeah. So this is important. Usually we always tell them and advocate using bigger, larger cubital veins because these are large. They will provide good flow rates. We need at least 15 ml of blood. So large veins will obviously give more. Then drawing from large vein, we can get the platelets without much lysis. It will minimize the turbulence. It will preserve their function and number. And obviously cubital or this area veins are easier to access and stabilize, less discomfort for the patient, less pain. And there is less risk of thrombophlebitis, hematoma instead of using peripheral veins. So we always use whole blood from cubital veins. So after the first spin, we collect it in our anticoagulant tube and we give the first spin. It comes as 3 layers like this. So at down, we have the layer of erythrocytes. Then this is the buffy coat, which contains our platelet-rich plasma. And the above supernatant solution contains the platelet-poor plasma. So after this spin, we take that first 2 layers, the PPP and the buffy coat, and we transfer that into the second tube. Right. So this is how we collect. So this is our the first PRP tube. We collected from the cubital vein. This is actually the GFC tube. I just wanted to show you the picture. I'll be telling that in the coming slides. Yeah. So we use, this is a 2.5 ml tube, which contains sodium citrate. So we collect at least 6 tubes like this, 6 tubes of 2.5 ml blood. So approximately 15 ml of blood is collected. After the first spin, the first and the second layers are transferred to the second tube. This is a 4 ml tube without an anticoagulant. Right. And this is the GFC tube. This is how it's marketed. It comes from the company just like this. This is actually a gel which prevents mixture of the blood and the platelets. It provides a good separation. So this is the GFC tube. Right. So after the first spin, this is how we get, this is after blood has been collected in both the tubes. So always, even the recommendation in that PRP Taskforce that I mentioned is using a REMI R8C plus centrifuge machine. This is what we usually use. This is digital, but we can manually change the rotations per minute, even the time, everything can be customized over here. This is how we keep the tubes. Right, opposite, it should always be weight balanced. This is the centrifuge machine. Right. So we collected the blood, right? So this is after the first spin. You can see erythrocytes in the bottom, the buffy coat. I don't know if it's visible here. It's in the middle, and above you have the platelet-poor plasma. So these 2 layers are then aspirated and put into our second tube. This is the GFC tube. I'm just showing you side by side. So earlier we saw this platelet gel, this fibrin glue, which was down. After centrifugation, it came to the middle. So it's effectively separating the platelets from the blood. So for GFC, we only need 1 spin. We aspirate this and directly inject. Right. So this is after the second spin. We got our PRP, which is ready to inject. Right. So we collected the blood and we did our first centrifugation. Second centrifugation is done. So this is how it's recommended now. The first spin at 1300 for 15 minutes and the second 1600 again for 15 minutes. This is after they've done their thorough search. This is what they've come up with. We have been doing these parameters for many years since we started in our department. Until now, there's no, I think it's almost similar. But yeah, if you're doing it for the first time, it's always better to follow the guidelines. Right. So we aspirated the plasma, the PPP and the platelet-rich, and this is how we finally get it. We collect you'll get about 4 to 5 insulin syringes of PRP, and this is how we inject. 1 to 1.5 centimeter apart, follow a grid-like pattern all over the scalp, usually intradermal or subcutaneous injections. That is how you inject the PRP. I hope the method was clear to everyone. So always the double spin manual method of preparation is what is pan-India wise recommended. If you go to any conference or any senior doctors, this is what they say. The double spin method is always better. So this is a better because of the low cost. You get a very good platelet yield. Single spin, and when it was compared, the platelet yield was very low. 53% only it was got. After double spin, you get a better yield of platelets. Right. Now there are 2 techniques. So what I've mentioned all this time was the open technique that we use. That is the manual or the open preparation of PRP. So in this, the blood is encountering environment in the working area. We have to sterilize everything separately. That is the open technique. Now you've heard of these commercial PRP kits, devices that these companies bring about. Those are all the closed techniques of the commercial preparation. So here there is nothing exposed to the environment. It's said to be more sterile. Right. So let's compare the both. It's always a question, is that better or should we use commercial kits? So the advantage of a manual open method, it's very low cost. You only need centrifuge, a few syringes and tubes. So if you're in a resource poor setting, if there is a lab, there'll definitely be a centrifuge machine. You can do this. Okay, it's customizable. We can change everything, especially if you're working in medical colleges. It's good for research because we can change the protocols. We can customize the settings. Limitations, like I said, everything is open. So sterility might be harder to maintain. It's dependent on the operator. You need skill, and there is a longer preparation time for the manual method. Whereas comparing the commercial ones, the advantage, obviously, it's sterile. It is standardized. So there is a consistent platelet yield. It's time efficient, and maybe it's certified. Most of these kits, not all, some of them are certified. Limitations, obviously, it's very expensive. Per kit, it's going to be very expensive. You can't customize anything. And firstly, what I've noticed in commercial kits is there is chance for side effects. 2 of my friends, there is a chance for pyrogen to be present in these kits. So the patient can come out with very high fever for a few days. So that is a big risk in commercial kits. So I think if you have a lab with you, a standard resource will always be better to a manual open method, provided you sterilize everything properly, use good all these gloves and everything, maintain the sterility. So that was the main difference. So these are the facets. Many of this I already discussed, the number of spins, about the anticoagulant, the centrifuge parameters. Few things I again want to bring into your, this thing is about the blood draw, the activation again, and about the platelet yield. Right. So the blood draw, I told you, a wide bore needle must be used from larger cubital veins. So this actually, what do you say, a D-dimer was done. A D-dimer level was assessed by Lippi et al. And it was with smaller gauges of needles, a lower platelet count was actually observed. That's why this sort of recommendation came about. And the time of blood draws always, don't delay it, because once you take it, if it exceeds 120 seconds, the platelet is going to clot. That's why I tell my patients also, when we take the PRP, at least within 15 to 20 minutes, we have to inject it. So they'll tell, we'll give the blood, we'll go and come. No, make sure they are there so we can inject it immediately. Okay, that's about the blood draw. Activation again. So like I said, collagen, so when PRP is used for hard tissues, this is what you have to understand, bone fractures, activation is a must. But when we do it into soft tissues, the research says that it does not need to be activated because our natural collagen is already going to act as an activator. That is about activation. Yeah, so actually both were compared in use in androgenic alopecia, and significant more increase in hair count was seen in non-activated PRP. Okay. Right. Now the platelet yield versus the purity. So this is actually maybe a comparison for the open and the closed methods. The methods that, that advertise to give higher platelet yields are actually not pure. But the methods that have pure PRP often have poor yield. So in the commercial kits, maybe you might be getting pure PRP, but the yield might be lesser. So platelet yield is not, it's actually inversely proportional to the purity of PRP. Okay. Now, this is maybe one thing that you all have noticed, that the final platelet-rich plasma, you might be getting, it might be mixed or reddish. This is absolutely normal. A few erythrocytes would have gone into the PRP. That is normal. That doesn't mean it has become impure. Okay. Right. So these are some terms. Now patients are going to come and ask you, I want to do exosome, I want to do QR678, biofillers. So at least be ready with what all these means, and you can maybe get some contacts with some companies and see what is available, the price, everything you should be aware of, because people are going to come and ask you. I've had patients coming and asking me very specifically, which activator are you using, ma'am? How many spins are you doing? They are well read. Even though it is half-baked knowledge, they've read a lot and they're going to come and ask you. So we'll come into growth factor concentrate. Now it is popular. Everyone is doing it because they've sort of decreased the price of the tubes at least a bit. So it's a commercial product, which is made by only one company as of now, I think, in India. It's also called the HPL, Human Platelet Lysate. So in this, there are a lot of growth factors and cytokines. Here I showed you that tube before. It's a 10 ml tube. We do just one spin, 3,400 for 10 minutes. Yeah, so this is the tube, how it comes, and you have the gel separator. It's divided into, and this product you can directly inject into the scalp. So this is a refined therapy. So it concentrates only the specific high purity growth factors, eliminating platelets and other components. So it's more potent and it's a very targeted treatment for hair follicles. And the advantage is it requires fewer sessions when compared to PRP. And if patients, you should never cave in for that. But when patients come asking for significant fast results, maybe this is something that you can offer. So a difference is growth factor concentration will be high in GFC. It's a specialized kit. Cost is higher, but the research is very less. Even now, this comparative studies of PRP and GFC are less. Sessions required are lesser compared to PRP. That is the difference. BIOTIN. BIOTIN is, along with the PRP injection, you can inject BIOTIN also to the scalp. It's shown to increase hair density and thickness. Again, research is less in this area. QR68 is also something that came up like GFC. It was made by these two doctors. So QR, we talk about the QR code. It's called quick response. The 678 is a Morse code, which means help or fast, something like that. So QR678. So this is also specialized kits that is quite expensive, sold by the company. And it has polypeptide and a growth factor solution that can be injected. That is QR678. Exosomes are preparations also coming up nowadays. But again, these are not FDA approved, and it's mesotherapy, basically. So it is a little, you have to use these with caution, because research is not available, side effects have not been studied, but at least know that all these are coming up. These are the newer things that you should be aware of. Now, PRFM is something, it's very useful. We have done it for a few patients in our department. It's platelet-rich fibrin matrix. So it's more effective than PRP for wound healing, and because it yields more growth factors and more platelet. So for all these ulcers, hard to heal wounds, platelet-rich fibrin matrix is very useful. So we withdraw blood and we directly centrifuge it at 3,000 for 10 minutes, and we'll get 3 fractions of it. So the middle, you get it like a clot. I think I have a picture. Yeah, you get it like a clot over here. You can extract that with forceps. This is how we get the platelet-rich fibrin matrix. So this is directly applied onto the wound, onto non-healing ulcers, and you can see such a good improvement was observed after 5 weeks. So this is something that you can easily prepare in the department for non-healing wounds like this, platelet-rich fibrin matrix. Right. So now we'll come into the complications. So injection site reactions, as for any injection site reactions, we always have to be aware of. bruising and bleeding, maybe hematoma formation. Infections can happen. So if the patient calls you at night or the next day telling they have high fever, so probably some contamination has happened. Or like I said earlier, a pyrogen would have been present if you have used commercial kits. So always be careful. And if it's a high load center, you're getting a lot of patients, always label and mark all your tubes correctly and use aseptic precautions. Tissue damage and nerve injury can come from poor injection technique, especially if you're injecting for periorbital melanosis, be very careful. Okay, these all happens due to poor injection technique. Then the less common ones, blindness, like I said, for periorbital melanosis. And even when you're injecting into the face for doing the so-called vampire facial or for rejuvenation, be very careful. Vascular occlusion can happen to the corneal artery, and that is a major side effect, but it's less common. Skin nodules can develop. So this sometimes even on the scalp, face, and all these really firm nodules develop like this. So this you have to investigate, take a biopsy. Most of this will have a foreign body granuloma reaction. And also you should rule out any underlying sarcoidosis or differentials like that. Allergic reactions, even though the risk is very low because it is autologous, it is still possible. So be on the lookout for that. Herpes zoster, like in any cosmetic procedure, especially lasers, we do ask a history of herpes or this thing. Even for this, you should ask because herpes zoster can get reactivated when you inject around the eye and even on the scalp. So these are the lesser common complications, right? So how can you prevent these or the risk factors? How can you prevent? Hygiene, obviously, because we are using a multi-step process. Make sure in each step you are using aseptic precautions, properly sterilize all your instruments. In proper technique, always go for proper training. Untrained professionals there might be improper technique. And because of the lack of standardization, so because many people use different RPMs for the centrifuge, different activations, so lack of standardization can also cause risk factors and complications. So try to use standardized, well-known, evidence-based techniques. So always go to licensed professional. That is a major challenge nowadays because everyone is venturing into this field. So always try to go to proper licensed professionals and always set up a follow-up system. We did the procedure, then we should be competent to address the complications also. So encourage the patients to keep reporting to you if any adverse events happen and keep monitoring them. It is your responsibility. You have to keep monitoring it. Okay. Right. So this, I hope sir doesn't mind. I just want to show you the trend in PRP that we've been noticing. You can see by the 2019s and all. So how much of a boom it became. Then again, COVID took a hit. Even then per year, we were having more than 200 patients coming in for PRP. Again, 2024 was a huge boom. So what I feel happened is patients do want proper doctors or dermatologists to do their procedure for them. They do come back to us because maybe the way we counsel them or the way we are not going to give them miracle cures or tell just one sitting is enough, you're going to get a lot of hair. They need their expectations to be realistic and probably they're getting that from us. So you can see. And 2025, this is our mid-year data. You can see it's probably going to be the same as 2024. So this is the trend that we are seeing now. The what do you say, the time mold open method, centrifugation. Now we use GFC tubes. All that patients are happy with it. Okay. So where do we stand now? So this, I think most of the scholars over here, I don't know if you're from North India, but this was a well-known PHC in Northern Kerala. So they brought out this advertisement of PRP and it was a huge boom. Even before that, I think my professors had already started doing it, but that's what the advertisements and word of mouth for cosmetic procedures are, it plays a big role. You saw Kim Kardashian doing that picture, such a boom it created. So after this, we got a lot of patients who weren't getting appointments there coming to us. So honest communication is what is needed and patients are happy with that. Tell them this is not a miracle cure. This is only going to support. Don't stop your minoxidil and your finasteride and depend only on this. And tell them about the prognosis. If they want, they can go for transplantation. All this honest communication is very important, I feel, for PRP. So the tips, results are subtle, gradual, and in each session, try to document, take good photographs so you can keep telling the patient, and do a trichoscopy also. All this will help in gaining the confidence of your patient. You can tell them, see, in this volume of hair, this much hair growth has come, and tell them it's not a miracle cure. It's only an adjuvant. Do not stop your main treatment of minoxidil and finasteride. And ask them, tell them maybe 30, 40, just commit that much, but there will be good improvement over time. I've seen patients who are very consistent with their medications, are very good at coming for PRP also. So they have good results. So these are the things I wanted to share in PRP in dermatology. I hope it was useful for everyone. So thank you.
Hello.
Yeah.
Yes,
Yes,
sir.
It's a wonderful talk. In fact, Dr. Roshan has put PRP very simple to everyone who are intending to use it. But of course, it requires a lot of practice, lot of sincerity, and lot of effort. So that is what is required. You have to see how she is preparing the PRP and how it is being injected. All these are taken meticulously, and that's why she has good results. So follow the principles which she has delineated. Think of various problems and its remedies. So then you will be a good person who could inject PRP. So thank you, Dr. Roshan, for your beautiful talk on PRP. Thank you very much.
thank you.
Thank you, Dr. Roshan, for your lucid presentation. To the postgraduate, thank you for joining us with this webinar. And I think you will all be benefited with this webinar. Kindly attend in the webinars also. Thank you very much.
Thank you, Doctor. So East West Pharma is always committed for continuous education program for the doctors, and we extend our gratitude to the speaker. Dr. Roshan Mary ma'am has given lucid presentation benefit for the PGs, and also we extend our gratitude for Dr. Kaitan sir is continuously conducting the programs for our East West Pharma for the benefit of the PGs. And have a great day to all.
Bye.